So next up we have that which is not closely related to the capitate bone. So this is a question where you need to have a good understanding about the anatomy. So let me explain this with this diagram. So here we have the proximal as well as the distal row of the carpals. We have the scaphoid, lunate, triquetrum, and pisiform. And then we have the trapezium, trapezoid, capitate, and hamate. Now they have asked that which of the structure is not closely related to this capitate bone. So there would be different options, and the option that you will be selecting as not in relationship would be the ulnar nerve. Now, ulnar nerve and ulnar artery are going to pass from this side. So they are at a distance from the capitate bone. To have a better understanding about this area, you can also consult the Netter's diagram to have a good understanding about the spatial relationship of different carpal bones and different structures, because on this side there will be the radial artery. It will be dividing into superficial branch going downward, and similarly it will be giving a deep branch to form an anastomosis over here. Similarly, an ulnar artery is going to give the deep branch and also going to give the superficial branch as well. So there is a lot of relationship that you need to understand in this area. So this in this way, there will be the superficial arcs and there will be the deep arcs and different structures. So to have a better understanding, also consult Netter's diagram as well. So next up we have a 32-year-old man who got stabbed in the neck. Inferior trunk of the brachial plexus is injured. Now, which modality is least likely to be affected? So for this, we have to understand that what the inferior trunk is contributing. So inferior trunk is going to become or contribute to the medial cord, and it is contributing mainly to the ulnar as well as some part or half part of the median nerve. Whereas it is also going to give the medial pectoral and cutaneous branches. Now, the modality which will not be affected will be that initiation of the abduction of the shoulder will be minimally affected because it is caused by the supraspinatus, and supraspinatus muscle is supplied by the suprascapular nerve. Now this is one of the branches which is given by the superior trunk. So basically it is a type of question where they want you to understand the difference of the structures which are originating from the upper trunk as well as from the lower trunk. So that is an important point. So with the ulnar nerve, there will be a problem with the flexor carpi ulnaris and the medial half of the flexor digitorum profundus in the form of muscles, whereas with the median nerve, the rest of the flexors will become affected. So, whereas this is the nerve which is coming from a very upper area, that is the superior trunk, so this will not be affected. So next up we have a 43-year-old woman who had her axillary node clearance following a positive sentinel node biopsy. Which nerve is at greatest risk? Now, this is the area which is very frequently tested in the exam. So here we have pectoralis minor, which is dividing the axillary artery as well as the axillary lymph nodes. Now, pectoralis minor divides axillary artery in such a way that the area which is medial is known as the first part. The area behind or beneath pec minor will be the second part, and the area ahead of pec minor will be the third part. Whereas the axillary lymph nodes are named in reverse pattern. That is, the area which will be lateral most will be the first group, then we have the second group, and then we have the third group. Now, in this area, there are important structures which include vessels and nerves. Now, regarding the nerve that is going to be injured is going to be the thoracodorsal nerve, which you could see that this complex of thoracodorsal vein, artery, and nerve is present in this area. So long thoracic nerve is also at risk. The thoracodorsal nerve traverses the level 2 of the axillary lymph node, as you would also appreciate that they are present near the level 2, they are present behind the pec minor. Now, there are other structures which are at risk, and that includes the intercostobrachial nerve and the long thoracic nerve. Now, the important thing is that either they can ask you about specific nerve or they can give you a clinical hint and then you will be identifying the nerve. So, for intercostobrachial nerve, they can give you a similar scenario, but they will add that the patient developed numbness over the medial area of the arm, this area, and they develop numbness. Then the answer would be intercostobrachial nerve. However, if they give you in the scenario that the patient is having some problem with the winging of the scapula, they give you a picture of that, then the muscle affected would be serratus anterior and the nerve damage in that case would be the long thoracic nerve. So you have to understand all of these things in detail to have a good understanding and get your MCQs very easily. So next up we have that which structure is not closely related to the brachial artery. So here we have the option as cephalic vein. Now, you need to understand that cephalic vein is present on the lateral side over here, whereas in between brachial artery and this there will be a lot of structures, and specifically brachial artery is present on the medial side or completely opposite side along the humerus in the arc. So that they can give you different structures. So the most distal structure or not closely related structure to brachial artery is going to be the cephalic vein. So next we have a 73-year-old lady who had a complex fracture of the distal aspect of her humerus with associated radial nerve injury. Now, which movement will be most impaired as a result? So we have to understand that if there is a radial nerve injury in the axilla, then all the extensions will be damaged at the elbow and at the wrist joint. But if there is radial nerve damage below the level of axilla at the spiral groove, then the radial nerve had already given supply to the triceps, which is inserted over here, and in this area, that is the level which is described in this MCQ, elbow extension will be spared. So elbow extension will be either fully present or weakly present, whereas wrist extension will be still completely absent. So you need to know that levels at which radial nerve can get injured and what will be the clinical picture. So in axilla, there will be absence of elbow extension as well as absence of the wrist extension. So that is the difference between the two levels of injury of the radial nerve. So next up we have a 23-year-old climber falls and fractures his humerus. Posterior approach to the middle third of the bone was used. Which nerve is at greatest risk in this approach? So these MCQs having different statement but having same answer. So the concept is to build you an idea that which of the areas can be tested, and there are different ways that they can be tested. They can simply ask you that which nerve is present or passing through the spiral groove. They can ask you that the fracture of humerus causes damage to which nerve, and they can even relate it to a clinical operative scenario that this approach was used. And so in all of these approaches or fractures, there is only one nerve that is damaged, that is the radial nerve. But over here in the medial condyle area, ulnar nerve can get damaged. That is an important thing. And similarly, in this area of lateral condyle, again, radial nerve can get damaged. So you have to be very much clear about these areas and specific nerves. So next we have a 43-year-old lady whose axillary node clearance for breast cancer has been done. During clearance of level 3 nodes, there is sudden development of risk hemorrhage. The most likely vessel to be responsible is, so as I've explained, that this is the area which is frequently tested. The nerve damage, the vessel damage, these all are, you can find them in these MCQs which I'm explaining in different ways in different scenarios. So previously they asked about the nerve, now they have asked about the vessel. So the nerve was the thoracodorsal nerve, but the vessel is the thoracoacromial artery. So thoracoacromial artery is one of the branches from the second part of the axillary artery. And we know that pec minor and all this area and axillary artery are very closely related. I've explained that different nerves can be asked, and this is the question where we have discussed about that which vessel can get involved. So next we have that which nerve is directly responsible for innervation of the lateral aspect of the flexor digitorum profundus. We know that it is supplied by the AIN, which is one of the motor branch of the median nerve. So median nerve is going to give the AIN, and AIN is going to supply the lateral half of the FTP, that is the flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. So a patient sustains damage to the median nerve during carpal tunnel release. Which muscle will be affected? So they can give you different options, and out of that, you have to see that either opponent's pollicis, abductor pollicis brevis, or flexor pollicis brevis is present in the option or not. Because median nerve, while passing from here, are going to supply the thenar muscles, which is the only supply of median nerve within the hand. It also supplies these two lumbricals which are present on the lateral aspect as well. So the answer in this case would be the abductor pollicis brevis, but you should also be aware that these are the other muscles which can be present in the options. So you have to be clear about that. So next up we have a 45-year-old man who had weakness of the hand. He's been given a piece of paper to hold between the thumb and index finger like this. So when the paper was cold, the patient had difficulty maintaining the grip of the paper. Now grip pressure is maintained by the flexion of the thumb at the IP joint. Now which nerve is most likely to be injured? Now this statement's part is a bit confusing, but regarding the rest you have to understand the concept. So adductor pollicis is the muscle which is responsible for this movement. So adduction is the movement that is towards the center or towards the medial side of the body. So if you give someone to hold between the thumb and the index finger, now this towards the center movement of the thumb will be conducted by the adductor pollicis. Now adductor pollicis is one of the muscles of the thenar group which is supplied by the ulnar nerve. So ulnar nerve is going to supply this. Now if we talk about in more detail, the deep branch of the ulnar nerve is going to supply the adductor pollicis. And all of this test is known as the Froment's test. Now this is the test which can separately be tested, that Froment test is used to test for. The answer would be adductor pollicis. So the next question scenario could be that adductor pollicis is tested by Froment's test, and in this scenario we have the adductor pollicis being supplied by the deep branch of the ulnar nerve. Now there is an important concept that there are two flexors. One is the flexor pollicis longus, and we have the flexor pollicis brevis. Now flexor pollicis longus is supplied by the anterior androgeus nerve, whereas flexor pollicis brevis is supplied by the median nerve. So next up we have a 32-year-old lady who had her carpal tunnel syndrome. Now the carpal tunnel was explored surgically. But the question is stating that which structure will lie close to the hamate bone within the carpal tunnel. So basically they are going to test your knowledge that whether you are aware of all the structures, because hamate, capitate, trapezium and trapezoid are going to form very close boundary of the carpal tunnel. So here we have 4 tendons of the FDS, 4 tendons of FTP and 1 tendon of FPL, and median nerve is also a component of the carpal tunnel. So apart from the options, you will be selecting any option which is one of the component of the carpal tunnel, and in this case the tendons of the FDP. So next we have a 42-year-old lady who had an axillary node clearance for breast malignancy. Post-operatively, weakness of shoulder unable to push forward from a wall with the right arm and scapula is pushed out medially. So this is very important. So which is the nerve being damaged? So as I've explained previously, this is the scenario where they have described winging of the scapula. So basically, winging of the scapula is because of the long thoracic nerve. But here they have also described a difference that if the winging is present on the medial side, then different muscles and nerve are going to be the answer. And if they have described the word lateral, that the winging is present on the lateral side, then what is going to be the answer? So for the medial side, we will be having serratus anterior and long thoracic nerve. Whereas if the winging is present and it is more predominantly towards the lateral side, then the muscle damage would be trapezius and the nerve would be the spinal accessory nerve. So that is the difference that you need to know because it's a new thing that you have to add. So next up we have that which muscle would be affected if the radial nerve were to be injured in the humeral shaft fracture. So this is one of the extension of the previous concept that one either they can test you for the nerve or they can test you for the clinical picture of the area that is involving this nerve damage, that is the radial nerve. So the muscle that will be affected will be out of those muscles which are being supplied by the radial nerve. So that would be the supinator. So what are other muscles? So for radial nerve, the mnemonic is best, that is brachioradialis, all the extensors of the forearm, supinator and triceps. Regarding brachialis, I would like to add that it is one of the flexors which are being supplied by the radial nerve, and among the extensors we have the extensor pollicis longus, extensor pollicis brevis, we have the extensor indicis, extensor digitorum, and extensor digiti minimi. Now, also there will be the abductor pollicis brevis and abductor pollicis longus. These are the muscles which are going to be supplied by the radial nerve. So next up we have a 33-year-old man who injured his forearm and wrist. Now he is unable to adduct his thumb. So this is again the same concept which I have elaborated. So the answer would be the deep branch of the ulnar nerve. So I have added these diagrams to help you visualize in your revision so that you do not have to go to any other resource after you are done with your first read. So here we have the opponens pollicis, abductor pollicis brevis and flexor pollicis brevis. These are supplied by the median nerve and adductor pollicis being supplied by the ulnar nerve. So which muscle is attached to the anterior aspect of the fibrous capsule that encases the elbow joint? So answer here would be the brachialis. So brachialis takes its origin from around the middle part of the shaft of the anterior aspect of the humerus, and that it inserts on the ulna, and it is also in that area where the fibrous capsule of the elbow joint is present. So brachialis inserts its some fibers into the joint fibrous capsule. So that is the area which is going to have its insertion, and the function is to flex the elbow joint. So the parts of the brachial plexus are related with, I guess we have discussed this part before. So the answer would be the axillary artery. So axillary artery is basically present in this area, and the trunks are actually named in relationship to this. So we will be having a medial cord, a posterior cord and a lateral cord in relationship to the axillary artery. So a 25-year-old man got stabbed in the upper arm. The brachial artery is lacerated at the level of proximal humerus. A nerve lying immediately lateral to the brachial artery is, we have discussed this as well, the answer would be the median nerve. So here the brachial artery has a lateral relationship with the median nerve, and then the median nerve will become anterior and eventually it will become medial to that. So which muscle is responsible for causing flexion of the interphalangeal joint of the thumb? So the answer would be flexor pollicis longest. Now, there are certain muscles which are specifically associated with causing different movement of the thumb. We have two flexors. One is the flexor pollicis brevis and one is the flexor pollicis longus, and they are both present on the anterior aspect. One, the FPL, will be having a long origin from the forearm, whereas the flexor pollicis brevis is having origin and insertion within the hand. Similarly, we have the two extensors. We have the extensor pollicis brevis and longus, which are going to be present on the extensor surface, and the longus will be inserted at the distal phalanx and the brevis will be inserted at the proximal phalanx. But then we have two abductors. We have the abductor pollicis brevis, which is part of the thenar group, whereas the abductor pollicis longus is an individual muscle which is present on the extensor aspect of the head. Then we have one adductor. Now, adductor pollicis is part of the thenar group. But then we have another specific muscle, that is the opponens pollicis. It is also part of the thenar group. So, not only we need to know that which muscles are responsible or are associated with the thumb, but we should be very much clear with their nerve supply. So, all these three will be supplied with the radial nerve. Adductor pollicis is supplied by the ulnar nerve, whereas these three are supplied by the medial nerve. So, thumb is a component of the hand which has innervation from all the three nerves. So, this is very important. So, next up we have that which ligament keeps the head of the radius connected to the radial notch of the ulna. So, here we have the head of the radius and there will be having a notch in the ulna. So, this is the annular ligament which is present like this, and it is going to keep this radial head into its place. So, 24-year-old female presented with tingling of hand after a fall, found to have a fracture of the medial epicondyle. So, nerve related to the middle epicondyle, that is the ulnar nerve. So, this is the this is the diagram for visualizing this concept, that here we have the humerus and we have the ulnar nerve. It goes down and then it goes behind the medial epicondyle like this. Now it passes through the cubital tunnel. You do not need to know much detail. It is a retinaculum like structure which is present over this area, which allows the passage of the ulnar nerve at the elbow joint. Here we have the furniture teres and we have radius and ulna as well. So, into which structure does the superior part of the fibrous capsule of the shoulder inserts? Now, it is inserted superiorly into the anatomical neck. Now, Cadet has explained that the fibrous capsule attaches superiorly to the anatomical neck and inferiorly with the surgical neck. So, here we have this is the capsule. Now, it will be inserted superiorly in the anatomical neck and inferiorly it is present in the surgical neck. So, let's take some time to understand other different ligamentous structures which are present in this area. So, we have the CC ligament, that is the coracoclavicular. Then we have the AC, that is the acromioclavicular. We have the CA, that is the coracoacromial ligament. Then we have the coracohumeral ligament. Now, this coracoclavicular ligament is further divided into one medial component, that is the conoid ligament, and one lateral component known as the trapezoid ligament. So, you will be more interested to know their origin, insertion and direction for MRCS part B, but you are not required to know this much detail for MRCS part A itself. So, just have a look of this diagram to have an understanding that these structures are present over here. So, next up we have that which upper limb muscle is not innervated by the radial nerve. So, once you know that which are supplied by the radial nerve, you can very easily select the answer which is not being supplied by the radial nerve. So, the answer would be the abductor digiti minimi. Now, abductor digiti minimi is one of the muscles of the hypothenar. It is one of the muscle of the hypothenar, and the hypothenar are being supplied by the ulnar nerve. So we have discussed this mnemonic. So try to add more knowledge if you want. So next up we have that which structure separates ulnar artery from the median nerve, and the muscle is pronator teres. So this is one of the very important concept in MCQ. So I have found this very beautiful diagram to illustrate this concept that pronator teres have two heads, and the two heads are going to separate ulnar artery. Here we have the brachial artery. It is going to divide into radial as well as ulnar. So here we'll be having the medial nerve, and these two structures are being separated by the pronator teres, which is present like this.